Just to let you know, I'm an interventional cardiologist, so that means that I'm a plumber of the heart, and we extended our training in the last 10 years into being plumbing of other parts of the body, like the legs and the kidneys and the arms. So pretty much any artery of the body we can do plumbing with. We can clean it out and put stents inside. So interventional cardiology has evolved into the field of vascular surgery to a certain extent, and we're trying to do things without cutting and stitching, but just by sticking needles into the arteries. And I really can't take any credit for the wording plaque attack. That was Lauren's idea, so I'll give her credit for that. But essentially what we're going to talk about is what is PAD, which is peripheral arterial disease, and what is CAD, which is coronary artery disease, and is it really all the same, or is it two different disease processes? So we're going to start off talking about what is cardiovascular disease. So it's a very broad term, and it includes coronary artery disease, which is blockages of the arteries of the heart. It can include a myocardial infarction, which is otherwise known as a heart attack. Anything that causes hardening of the arteries is called atherosclerosis. It can include strokes, and many strokes, which we call cerebrovascular accidents, or CVA. It can include high blood pressure, heart failure, and finally peripheral arterial disease, which is blockages in arteries other than the heart, any other part of the body except the heart. So coronary artery disease, that's where we're trained as cardiologists. CAD is a major form of cardiovascular disease. These arteries are blocked by different things like cholesterol deposits, triglycerides. As they stay there longer and longer, these plaques get calcified, so calcium goes in there. And the net result is with the blockages that you have, you're decreasing the blood flow to the heart muscle, which is basically a muscle that just pumps. And that's all that the heart's supposed to do. And when you get chest pains, we call that angina. Cerebrovascular disease, on the other hand, is blockages in the brain arteries. These are the carotid arteries that are going up through your neck into your brain to supply blood to the brain cells. If you have a blockage here or inside the brain, then you're calling that a mini stroke or a stroke. And the only difference between a mini stroke is that the symptoms resolve in the first 24 hours, whereas a stroke symptoms continue beyond the 24 hours. And most of the time, the damage also continues. Well, the damage of the TIA, the weakness of the arms, or whatever your symptoms are, usually resolves within 24 hours. And again, this is damage to the brain cells, just like a heart attack. Think of it as a heart attack of the brain, because the blood cells are clogged with something, either a plaque or a blood clot. When you talk about peripheral arterial disease, or PAD, I want the public and also the doctors to be more aware of PAD, because even a lot of the medical professionals are not aware of PAD, and that's why we like to do these kind of talks, to make the public aware of PAD. So maybe they can make their doctors more aware of PAD also. And what PAD is basically exactly like coronary artery disease. These are plaques that develop in arteries other than the heart. I mean, talking about carotid arteries going up to the neck, talking about the arm arteries going down to the arms. You're talking about the aorta, which is the main artery of the body that brings blood flow to the abdominal organs and into the legs. You're talking about the kidney arteries. So blockages of kidney arteries can lead to hypertension. So blockages of the leg arteries can lead to what they call claudication, which is, and we'll talk about that in a little bit, but it's basically pain in the legs when you walk. Instead of blockages, the plaques can actually cause thinning or ballooning of the arteries, and that's called an aneurysm. That's a form of peripheral arterial disease also. And what this slide basically wants to show you here is that you don't only have coronary artery disease. Now, some people just have coronary artery disease. Some people just have cerebrovascular disease, like strokes. And some people, very few, have only peripheral arterial disease. But 38% of all of these patients have overlaps. So you could have coronary artery disease and peripheral arterial disease together, or a stroke and peripheral arterial disease, or a stroke and a heart attack and peripheral arterial disease. And the whole point of this slide is that these diseases do not occur in an isolated environment. They're all interdependent. And my best analogy to that is they're all arteries. All of these arteries were laid out at the time you were born. So it doesn't make a difference if if you have, let's say, a heart attack, you can still have a clogged artery into the brain. All of these arteries will clog up pretty much at the same time. And my analogy is a railroad system. If you have a train connecting, in New York we have Amtrak, the Long Island Railroad, all of those lines were laid out at the same time. So if there's a broken rail at the Jamaica station, there's a pretty good chance you're going to have a broken rail at Penn Station also, because they're all where the same wear and tear is going on in all those arteries all of those years. So think of these as a similar disease process, except it's occurring in different parts of the body. And it's really a public health crisis. 60 million Americans have cardiovascular disease at any one time. 50 million people can have high blood pressure. Coronary artery disease, which is the blockages of the heart arteries, can affect 12 million people at any one time. And 7 million can have an acute myocardial infarction. That's a heart attack for the first time. Angina, 6.3 million people. Stroke, 4 million people. Heart failure, another 4 million people. And again, people can have different diseases all going on at the same time too. And what's a toll? Heart attacks, acute myocardial infarctions, about 1 million of them happening every year in the United States. Half of them are recurrent. And about half of those, about 450,000, die from a heart attack. And most of them die before they get into the hospital. Lately, we actually have decreased the heart attack risks of all patients at this point. We have decreased that because we're getting them into the cath lab and doing an acute MI angioplasty, putting balloons and stents and unclogging those arteries. And we actually have decreased the mortality of heart attacks dramatically in the United States because of this goal of trying to get all of these arteries open within 90 minutes. But we're not doing as well with strokes because people are not coming in time. The people have stroke symptoms that they're not coming into the hospital within 3 hours so they can get a clot-busting drug, which may dissolve the blood clot in the brain artery and prevent further damage to the brain tissue. And every 33 seconds, somebody dies from cardiovascular disease. That's astounding. So when we talk about peripheral arterial disease, or PAD alone, that can affect 12 million Americans at any one time. Out of those, 2 million Americans have what we call critical limb ischemia. That basically means that their legs are ready to fall off. They either have gangrene, or they have non-healing wounds or infections of their feet, and they're ready for an amputation. So and they do about 100,000 amputations per year in the United States. It is mostly a disease of the elderly versus heart attacks you can get in their 40s and their 30s. I had patients that I put stent in them at the age of 29. I had people with heart attacks at 40 and 38. But PAD is usually seen in the older population. It's only 2.5% in the 40 to 59-year-olds, but it's up to 20% in the 70 to 79-year-old population. And when you look at the cause of death of all of these diseases, when you look at cardiovascular disease death, these are basically heart disease. This is strokes, and this is other heart issues like heart failure, and this is cancer. So the cardiovascular disease is by far the #1 killer in the United States, more so than any other disease entity. And down here you can see the deaths due to Alzheimer's, so it's really small. But for all age groups, cardiovascular disease is the #1 killer. And this is just a little schematic on how this process develops. And this is what we call atherosclerosis. This is hardening of the arteries. That's the common terminology. And it really starts in the first decade of life to start forming some inflammatory cells in the artery. This is a cross-sectional picture of an artery from here to here. So this is what's developing in the first decade or second decade. And we know this because when they started doing autopsies on young kids dying at the Vietnam War, these are 18, 20-year-old healthy kids dying in the war. They did an autopsy. They found signs of atherosclerosis in the coronary arteries. So that's how we know it starts as early as teenage years. And then the plaques keep on getting worse and worse to the point that it develops You have another pointer? To the point that it gets really tight and narrowed in your last, maybe I could do it this way, right over here. You can see this could be the 4th decade, and this is where you start getting the plaques getting more severe. Oh, this is a pointer?
Yeah, no, that plugs in.
Great, thank you. So over here, like in the 4th decade, you can see the plaque is accumulating more and more to the point that it may rupture. And once it ruptures over here, it can accumulate with blood clot and close off the entire artery. Now, once you have this much plaque in the artery, then you're probably going to be getting angina because you only have this much of the vessel open to get versus the normal vessel to get blood flow into the heart muscle. That way, when you walk, you may get chest pains, or you may get jaw pains, or you may get arm pains. If it ruptures, like over here, and your blood cells clog this up, now you have a blood clot there, so now you're going to have no blood flow into the heart muscle, and that's called a heart attack. So it's a disease that didn't start 2 days ago. That's what I'm trying to explain to you guys. It didn't start 2 months ago. It didn't start 3 months ago. It started years ago, and it's just slowly, progressively worsening. So what are the symptoms of coronary artery disease? Well, the first thing everybody talks about is chest pain or chest pressure or chest tightness. And the reason I'm using all of these adjectives is because nobody describes their pain the same way. Everybody will describe it as different kind of a pain. Most people say a tightness or a pressure. And it can radiate, meaning it can go either to the neck, to the jaw, to the arms, to the back. So not everybody will have the same symptoms, and that's why we have to be more cautious in not sending you home immediately from the emergency room until we get other blood tests or a second EKG or maybe other diagnostic testing to tell us whether you're having heart disease or not. Most of the time, it is precipitated by exertion. The heart muscle cannot keep up with the demands because there's a blockage there. There's not enough blood flowing to the heart muscle when you're doing some form of exertion, playing tennis or walking or going upstairs. On the other hand, you could get a heart attack as you wake up in the middle of the night. A lot of heart attacks happen early in the morning where the hormones raise your blood pressure and your heart rate because the body knows that you're about ready to get up. So you can get a heart attack 5 o'clock in the morning in bed, and you could wake up with a severe chest pressure, crushing chest pain, and you could be getting a heart attack at that point, and that could be pain at rest. Other symptoms could include shortness of breath, nausea, vomiting, sweating, and don't forget, a heart attack is not a subtle event. You're not going to say, I think my shoulder hurts a little bit. That's not a heart attack. A heart attack most of the time is considered something of doom. You're feeling a sense of doom. Something bad's going to happen. You just have a bad feeling inside of you. This is usually what a heart attack, most patients tell me at least, feels like. So a heart attack is basically, like I told you before, an occlusion of the coronary artery. And about 20 minutes or so, 20 to 30 minutes after the artery occludes, then part of the heart muscle starts dying. And when the heart muscle starts dying, then it releases enzymes in the blood test, and we start catching some of those enzymes, and those are the tests that we do in the emergency room to find out if you had a heart attack or not. The earlier we open up that artery, meaning with balloons and stents, the less damage you have to your heart muscle. And that's why we're talking about time equals heart muscle. Because the sooner we get it open, the better off you're going to be, the less heart muscle damage you're going to have. And the national goal is from the time you step into the emergency room, we need to have that artery open within 90 minutes. And that's the goal that everybody's striving to achieve. Every hospital across the United States is trying to achieve that. And I think Memorial is doing a pretty good job at trying to reach that goal. Now, there's extenuating circumstances. If you had a heart attack and you passed out and you hit your head, well, we can't take you to the cath lab. We have to scan your head, make sure you don't have a bleed in your head or you don't have any strokes or something else going on. Some things could delay that 90-minute rule, but everybody strives to get the artery open within 90 minutes. How about a stroke? Stroke is not a subtle event. It's not something that's going to get worse and worse and worse. It's a sudden event, and something happens suddenly. Typically, it's a weakness or a numbness. It could be the face or the arm, and it's usually one side of the body. It's very unusual to have symptoms on both sides of the body. If you have weakness on both arms, it's not likely to be a stroke. You can have loss of vision in one eye. You can have trouble speaking, either because your face is drooped on one side, because the muscles of the face are weak and you can't speak correctly, or the stroke has affected the motor and the speech part of the brain, and you can't get the word out that you want to say. And you see people typically of the left side of the brain with a stroke on the left side of the brain typically cannot find the words. They know what they want to say, they just can't say it. They can write it, but they can't say it. Or unexplained and severe headache. You can have dizziness, unsteadiness, or a sudden fall. Now, sometimes we don't know if that stroke, I think I'm coming to that. Causes of the stroke could be what we call an infarction, which is a lack of blood flow to the cerebral artery, to a brain artery. And that could be because of a blood clot that either formed in the brain because the narrowing of the artery, like I showed you before, a rupturing of the plaque and you develop a blood clot up there, or an embolus. An embolus is basically a piece of plaque or blood clot that traveled to the brain. That could come from the heart, from irregular heart rhythms. It could come from the aorta, where a piece of plaque breaks off and finds its way up to the brain. But an embolus is a traveling plaque. So it can happen from those two things, and that's typically what we see as a stroke. Much less frequently, you can have a brain bleed or a hemorrhage. And this also happens very, very rapidly, and you have the similar features. That's why you don't know exactly what's going on, even as a physician in the emergency room, until you get the CAT scan and you see that there's bleeding up there, or if there's no bleeding, in which case you suspect it is a blood clot or a plaque that has embolized to the brain. Now, hemorrhages of the brain are a lot more dangerous, if you will, for the immediate well-being of the patient, because if it keeps on bleeding, it keeps on putting pressure on the brain, and the brain cannot expand beyond the skull. So it keeps compressing itself. The more blood is in there, the more it compresses the brain, and you can have a lot of severe brain damage in a very short period of time. So that's almost like a medical emergency, a hemorrhage of the brain. Stroke, we have a little bit more time. How about PAD symptoms? So we talked about coronary artery symptoms. We talked about cerebrovascular symptoms. So peripheral arterial disease symptoms. Most of the people have no symptoms. That's why I highlighted that. You can have plaques in your arteries, in your kidneys, or in your arms, or in your legs, or in your aorta, and you feel perfectly fine. Other symptoms, if it gets more severe, you can have cerebrovascular problems, like brain problems, clogged arteries in the carotids going to the brain. You could present with hypertension or kidney problems because of kidney artery blockages. You can present with arm weakness or arm pain, and that can be associated with a blocked artery going down to the arm. That's called the subclavian artery. And that would present, typically patients come in saying, I'm driving and I just can't keep this arm up. I have to put it down because it feels tired and weak. Or I'm carrying packages and my left arm is just getting weak and I can't carry as much as I was carrying with the right arm. And you think, I'm just getting tired, I'm getting old, or whatever. Sometimes people say I have to shake my hand to get it going again. And that could be a sign that you have a blockage in the arm artery. If you have blockages in the abdominal arteries, in the arteries that feed the intestines, you can have abdominal pain, belly pain, after you eat. And people become really thin and almost emaciated because they do not want to eat, because they know when they eat they will get pain. And that's a sign that some of the arteries in the belly are blocked up. And the most common form of peripheral arterial disease that we're talking about most of the time is what they call claudication, or pain in the legs. And typically what happens with claudication, actually I'm going to describe it in a second, but what happens with that is the legs are not getting enough blood flow, in which case when you get up and do something, walking, you get pains and cramps in your legs. And if it continues, you can get more pain at rest, or you can get non-healing wounds, particularly if you're a diabetic, or you can get gangrene that may lead to amputations. So this is what claudication is. This is what we talk about when you hear a doctor saying the word claudication. It's a specific syndrome. It's not, well, my leg hurts a little bit, that's probably arthritis or back pains. But claudication is that when you're at rest, you feel fine. Nothing's hurting you. Your back's not hurting, your leg's not hurting, your everything is fine. You start walking a defined distance, let's say 3 blocks. You walk 3 blocks, now you start getting pain, typically in your calf. Typically behind the calf, you start getting pain, you stop, wait there for like 30 seconds, pain goes away. So that's claudication. You get up and you walk again, those same 3 blocks, you're going to get the calf pain again. And depending on where the blockage is, if you continue walking with that pain, the pain will progress either to the thigh or even progress further up to the butt. And that's what we call butt claudication. That's a sign that the blockage is further up, really close to the aorta in the iliac artery. So that is claudication. It's not pain that comes and goes, you know, with rest, or my leg cramps up at night when I'm sleeping, or shaking at night. This is a defined syndrome. At rest, you have no symptoms. You walk a defined distance, always the same distance. The patients tell me, I can only walk 30 yards and I get the pain. You stop, pain goes away, walk another 30 yards, you get the pain again. So what are the leading risk factors? And that's why we're here to talk about it a little bit more. What are the risk factors for cardiovascular disease? Physical inactivity has a significant impact. High blood pressure, excessive body fat, what we call abdominal obesity, a low good cholesterol, HDL is a good cholesterol, or a high bad cholesterol, that's the LDL. Diabetes is a major risk factor for cardiovascular disease. Smoking, another major risk factor for cardiovascular disease. And clearly, if you have a family history of early heart disease, meaning, you know, your dad had a heart attack at 40, your mom had a heart attack at 45, that's early family history. Not my mother died of a heart attack at 91, that doesn't count. Obviously, age, the older you are, the more at risk you are for cardiovascular disease, and gender. And that is somewhat of a hot topic these days. It used to be that men had more cardiovascular disease, probably because men were more smokers at one point than women. I think women are probably more smokers now than men, and I think that I assume cardiovascular disease is just as equal in both sexes. Now, peripheral arterial disease is, like I told you, very, very similar to coronary artery disease. But the risk factors are also very similar, except for a couple of exceptions. Age it's much more common in the elderly. Like I told you, you typically don't get PAD in a 40-year-old. Although if you've been smoking 3 packs a day for 25 years, you could probably get it in them also. It's not as common as in the elderly, whereas a heart attack can certainly happen in a 40-year-old, a lot more common than having a plaque in the leg artery. Smoking is a much stronger risk factor for PAD than for CAD. So 80% of people with PAD who have intermittent claudication, that's what IC stands for, intermittent claudication, the syndrome that we just talked about, have used tobacco. So most of the PAD patients were ex-smokers or current smokers. Hypertension is not that big of a factor for PAD as it is for CAD. Diabetes is a big factor for PAD. With a diabetic, you have a 3- to 4-fold increase of PAD and a almost 3-fold increase of ischemic wounds. And a lot of times you have a lot more rest pain than non-diabetic. So I would tell you that for PAD, peripheral arterial disease, the strongest risk factors to get that is diabetes and smoking, by far. And why do we care about this? What's the big deal about PAD? Why are we here today? Why are we talking about PAD? Well, because if you look at patients with PAD over 5 years, about 1/3 of the patients will have worsening symptoms, meaning if they were walking 10 blocks before, now they're down to 3 blocks, let's say. 4% will have limb loss, means an amputation. Well, it doesn't sound that bad, right? Only 4% of the patients in 5 years lose a toe or a foot or whatever. Not that bad. 20%, though, have non-fatal heart attacks and strokes, and 30% will be dead in 5 years. Now, they're not dying because they're chopping their toes off or the legs off. They're dying from something else, and they're dying from cardiovascular disease. They're dying from strokes, heart attacks, kidney problems, kidney failure. But this is a significant statistic. You can't deny this. This is not, you know, well, maybe he has chest pain. Maybe the chest pain was not cardiac. Maybe it was something else. This is body bags. This is 30% of these patients with PAD over 5 years. And we're not talking about the sickest of the sick. We're talking about all PAD patients. So it's just a form of identifying somebody who is higher risk than somebody else. Now, if you happen to be one of those patients who has critical limb ischemia, meaning that they have a black toe, gangrene, or an infection, 30% will have an amputation in 6 months, and 20% will be dead in 6 months. Not 5 years, 6 months. So this is one of these people are probably the sickest of the sick patients at this point. So that's why we're interested in PAD, and that's why we're trying to figure out ways to prevent cardiovascular disease and PAD in general, and we're trying to make everybody aware of this so maybe they can go to their medical doctors and say, hey, listen, do I have PAD? So how do you prevent this? Well, there's 2 ways. Either you do primary prevention to prevent a first heart attack or a stroke or some other problem, and that's why I'm taking cholesterol medication so I won't get a heart attack. That's primary prevention. Secondary prevention is once we have a patient with a heart attack, what do we do to them to prevent them from having another heart attack or having a stroke after the heart attack or another stroke? That's secondary prevention. And all of these techniques involve controlling of diabetes, controlling of the blood pressure, lowering your cholesterol levels. The major thing is quitting smoking and starting to exercise. All of this is what we call lifestyle modification. You got to change the way you're living. And obviously there's medications that we can also give you to do all of these things. So you got to know your numbers. You can't go to the doctor. I think you really can't go to the doctor and not know what your sugar is if you're diabetic, and not know what your cholesterol is, and not know what your A1C is, and we'll go through all these, and not know what your blood pressure is. I mean, you may have to think about it or write it down, or, you know, it's like, how old are you? I don't know. I was born in 1955, so I have to do subtraction and figure out how old I am right now. You have to think about it a little bit, but you should know your numbers. And be on top of your doctors. A lot of times, things fall through the cracks. Doctors are very busy, and they run in, they run out, they look at the labs, or, okay, it's okay, so you go down, or you didn't turn the other page. You know, be a smart consumer. Okay, when you go to the doctor's office, most of the time, you listen to what the doctor says. When you go buying a car, you probably go around and do some research on the internet and find out what the price of this dealer is versus that dealer is, and you're doing more work buying a car than going to the doctor and being in charge of your health care. Be more in charge of your health care. That's all I'm asking. Know your numbers. Total cholesterol should be under 200. The current recommendations is that your bad cholesterol be under 130. Now, that's for normal people, okay? That doesn't include you if you have hypertension or high cholesterol or diabetes or a smoker. That's for everybody. Normal people, LDL under 130, HDL over 45. Good cholesterol over 45, bad cholesterol under 130. However, if you have 2 or more risk factors for cardiovascular disease, like we talked about before, diabetes, hypertension, high cholesterol, smoker, family history, things like that, age, 2 or more of those risk factors, your LDL has to be under 100. Never mind 130 anymore. You're not normal anymore. You have risk factors for CAD, under 100. Now, if I know that you have CAD or PAD, why? Because I did an angiogram on you and I know you got plaques in the arteries of the heart or plaques in the arteries of the legs, or I put a stent in your heart or put a stent in your leg, then your LDL has to be under 70. Never mind 130, under 70. And if you're diabetic, with nothing else, just a diabetic. You're diabetic and you're taking some some diabetic medications, oral medications, doesn't have to be insulin. Diabetes, LDL under 70. Why? Because it's only a matter of time before you get clogged arteries with diabetes. I tell my patients diabetes is the worst illness in the world. It will kill you slowly from the inside. It's worse than cancer. So you have to be very aggressive with cholesterol reduction and diabetes. And as cardiologists, we're pretty much aware of that. A lot of the general practitioners, a lot of times, are not as aggressive giving people lectures about cutting back your fried foods and your butters and taking your cholesterol medications. But we have to be very aggressive. Diabetes is what they consider a coronary artery disease risk equivalent. CAD risk equivalent, meaning it's the same risk. Whether you have CAD or you have diabetes, you're just going to get it at some point. So you have to be very aggressive to try to prevent coronary artery disease and cardiovascular disease. So know your numbers. How do you lower your cholesterol, your bad cholesterol, the LDL cholesterol? Well, you can start off eating diet low in saturated fat and cholesterol. Avoid fried foods, which is impossible in Lake Charles, from what I determined in the last month and a half. Absolutely impossible. Increase fiber intake, so at least won't let it last around in your stomach too long if you do have it. Use polyunsaturated fatty acids. Keep your cholesterol intake under 200 milligrams a day. You know, that's hard to do. You're not going to be reading everything that you eat and all that kind of stuff, but, you know, at least exercise. That's another key factor. And statins. Statins are the cholesterol medications that we recommend to lower your cholesterol. But not everything is a pill. You know, the whole point is, yeah, I can sit behind my desk and keep on writing prescriptions for pills every single day, but the patients have to take responsibility for themselves. They have to stop eating the stuff that they're eating that got them into this place in the first place. So, some more on LDL reduction. Avoid commercially baked foods. Why? There's butter in everything that you eat that's commercially baked or fried or cakes or anything like that. Avoid trans fatty foods. Drink lower fat milk. Now, that's not... I put that in there because some people could drink a gallon of milk a day, and if you drink a gallon of milk of regular milk, you get a lot of fat, so then switch over to low fat. But if you're just putting a little milk in your coffee, a couple of drops, that doesn't make a difference. It's the total amount of fat that you're taking in per day. Some of the worst oils will be coconut oil, palm oil, and cocoa butter. They're bad in fats. And if you can, bake, broil, grill, poach, or steam your food. Not fry it, okay? I think I saw a fried slipper around here with bacon wrapped around it one day, and I didn't try it, but I think you guys fry everything down here, including healthy stuff like vegetables. So, and avoid fatty sauces. Well, I mean, might as well move out of the area, I think, at this point. So how can you raise your HDL? That's not as easy, and that's not as effective. Aerobic exercise, believe it or not, increases HDL levels. The more you exercise, the higher the HDL will go up. Quitting smoking raises HDL. And weight loss raises HDL. Those are the only things you really could do to raise your good cholesterol. Medications, they haven't panned out yet. The only medicine that kind of raises HDL a little bit is what we call niacin, which is a B vitamin, which causes some side effects like flushing to go along with it. But that's the only kind of medicine that raises HDL. There was some research going on more recently from Merck and Pfizer about doing drugs that specifically raise the HDL, and they stopped producing them because they were killing more people than they were helping. So we haven't found a good HDL-raising drug yet. Why is high blood pressure a risk factor? I get a lot of that, a question in the clinic a lot of times. Why is my blood pressure a risk factor for heart disease? What does that have to do with the heart? Well, the heart has to generate the blood pressure. So the heart has to squeeze harder to get the blood to the legs and to the arms and to the belly when you have high blood pressure. So the harder it works, then it becomes thickened. And the more thickened it becomes, the less efficient it becomes. Then you have wear and tear on the arteries. And that's probably the more important risk factor for plaque formation with hypertension, because these arteries are on this constant high pressure, and I think the wear and tear on the arterial wall predisposes the cholesterol to get in to the arteries and the calcium deposits and starts making these cholesterol plaques. Know your numbers. Just don't accept your blood pressure is good. Don't accept that. Tell them, Doc, what was my blood pressure? And a normal blood pressure is the top number under 120 and the bottom number under 80. Not 124 over 84. That's not a normal. That's pre-hypertension at that point. And if you're being treated, you should be treated with this as a goal, 120 over 80. Stage 1 of hypertension is 140 to 159, or a diastolic of 90 to 99, and stage 2 is really severe hypertension, greater than 160 and greater than 100 on the bottom number. So your ideal goal, 120 over 80. Now, am I going to go up on your medications if you're 124 over 84? No, of course not, because I don't want to bottom out your blood pressure, but I'm going to tell you, cut back the salt. Don't eat that crawfish boil that you had yesterday, because that's going to be loaded with salt. So those are the things that you have to do to help me fix your blood pressure. And what else do you do? Well, I just said lifestyle modifications. There's our word again. Low salt diet, weight loss, aerobic exercise. We typically start treatment if your blood pressure is greater than 140/90 or 130/80 in patients with diabetes and chronic kidney disease. So we're much more aggressive in people with kidney disease and diabetics in treating their blood pressure, and we start at a lower number. And you will not be controlled with one medication. It's almost impossible unless your blood pressure is like 136/82, and I want to lower it a little bit. That will take one medicine. But if you're in the range of 140/90 or 150/100, you're going to need at least 2 different medicines. The average was 3.5 medicines in one of the trials to get your blood pressure normalized. So don't argue with a doctor if he wants to give you a second medicine or a second pill at that point. And diabetes increases the risk of cardiovascular disease and cardiovascular events. I think for the sake of time, we're going to skip that because I want to get to this. I think diabetes is an American epidemic. And this is basically a map of the United States. The darker the concentration is the prevalence of diabetes. Guess where we are? Right down here. And guess what's next door? And what's next door? This is the Deep South. Okay? Now, obesity. Okay, we talked about diabetes. Look at this map. This is the United States map. The darker colors is a higher concentration of obesity. Guess where we are? Right down here. And right next door to us. Deep South again. Look at these 2 maps back to back, or side to side. So obesity and diabetes, you think there's a connection? I think so. That's why somebody coined, not me, somebody smarter than me, coined a term, diabesity, as an epidemic. And I do believe that, actually, because diabetes and obesity goes hand in hand. I mean, this is 2007 data, but this came from the United States government. And when you look at the obesity rates from 1994 to 2008, look at these colors here. Okay, this looks like the fall in New York. This is what little yellow, and look how dark it became. And you're talking about 14 years. So we become a fat society, and we also became a diabetic society at the same time. Now look at these maps. They're identical, right? So diabetes and obesity goes hand in hand. Know your numbers if you're a diabetic. A1C is a primary target for glycemic control to show that your sugar is controlled. This is the average sugar, if you will, of a 3-month period. And it's a standard blood test these days, and a lot of doctors do that. If you're a diabetic, you need to have your A1C under 7%. If you have coronary disease and something else and other diseases, I will go to 6%. Although the lower you go, the more the chances you may have hypoglycemia, but I think that has to be individualized. As people get older and older, in their mid-80s and older, I try not to get too strict of a blood sugar control, because of the risk that they may pass out if the sugars are too low. But in a 50-year-old, I want the A1C to be 6% because I want him to make it to 80. And if he has an A1C of 11% or 9%, he's not going to make it to 80 from 50. I can guarantee you that. So obesity is an epidemic. And it's easy for me to sit here and say, well, he's obese and he's not, but we have definitions for that, and that's what I'm trying to tell you. The body mass index, or BMI, is the tool that we use to determine when somebody is overweight and when somebody is obese. So BMI between 25 and 29.9 is overweight. BMI of 30 or higher is considered obese. More than a third of the Americans are obese based on these criteria. And a very quick rule of thumb, look at your waist circumference. If you're wearing a size 40 or more pants, you're obese. And if you're a woman over the 35 inches, you're obese. So this is one way to look at it. Smoking cessation is imperative. It's imperative for PAD treatment. I could put you on Plavix and aspirin and cholesterol medication. I could put stents in there. You keep on smoking, you're going to have a problem with that stent and everything else. And you're not going to live long. When they looked at patients with PAD who continued to smoke over a 10-year period, they had about a 50% mortality, meaning half of them were dead in 10 years, usually because of heart attacks and strokes, like we said before. And if you quit smoking, Just quitting smoking. No stents, no nothing. You're going to be able to increase your walking distance probably double than what you had before, even with the claudication. So if you had a 3-block claudication that we talked about before, if you quit smoking, you may make it up to 6 blocks just by quitting smoking. So what are the exercise recommendations that we talked about? And this comes from the American College of Sports Medicine and the American Heart Association. So the basic recommendations is do moderately intense cardio exercise 30 minutes per day, 5 days a week. Okay? 30 minutes a day, 5 days a week, moderate intensity. Or do vigorous intensity, cardio, 20 minutes per day, 3 times a week, and at the same time, do 8 to 10 strength training exercises, like 8 or 12 reps of each exercise twice a week. And what does vigorous mean? That's going to be the question that I always get. What does vigorous mean? My definition of vigorous is when you're huffing and puffing. So if you're walking on the treadmill and you're talking on the cell phone, you're not exercising. You're just not. If you're walking on a treadmill and you're reading a book or the paper, you're not exercising. You have to get to the point that I have to talk to you later. I'm on the treadmill now. So that's vigorous exercise. Okay, so if you're not doing that, you're not doing vigorous exercise. Now, if you want to lose weight, you need to do about 60 to 90 minutes of exercise. Like combined, not only aerobic, but combining aerobic and muscular exercises. And what are the top 10 reasons to exercise? Number 1, helps keep the weight down. Number 2, reduces fatigue and increases stamina. It's incredible how better you feel after you get out of the gym than when you're going into the gym. Activates the immune system. You probably get less colds. It decreases the risk of diabetes and hypertension and heart disease and osteoporosis, particularly for women. It lowers your cholesterol level, improves your mood, and increases your life expectancy. These are all proven, so I'm not making them up. But this is my typical patient. My doctor told me to start my exercise program very gradually. So today I drove past a store that sells sweatpants. That's how he's starting. So do we have any medications that we can give you? Well, yeah, we do. But first of all, you need strict glycemic control in diabetics, as much insulin as it takes, or as many as medications as it takes to keep your sugar down and get your A1C around 6-7%. You need to do that. You need to take a cholesterol medication. You have to be in a cholesterol medication on a statin. You know, you can't do it alone. You can't do it just by cutting back the fried pork and the fried chicken. You need cholesterol medication. And these cholesterol medications have other effects other than just lowering the number of your cholesterol, which they do very effectively. They have plaque stabilizing effects. They have anti-inflammatory effects in the coronary arteries. So if you have PAD or CAD, you must be on a statin. Antihypertensive medications. Take as many meds as you need to control your blood pressure. Just because you're taking 2 meds and you don't want to take a third one, that's not a good answer. And antiplatelet medication. These are the ones that prevent the platelets from sticking together, like aspirin and Plavix. There's the newer one called Effient these days. But if those things don't work, and a lot of times if the disease has progressed extensively, then we need to go one step further to relieve patients' symptoms or improve their survival. And these are the interventional treatments. So we have balloon angioplasty, like we have for the heart, putting balloons and stents in the heart. We have specific balloons and different kind of devices and options for the leg arteries and for the abdominal arteries and for the arm arteries and the kidney arteries that we can fix. We could suck out blood clot from these arteries with thrombectomy devices. We could put stents, and we have different varieties of stents, balloon expandable, self-expanding stents. We're talking about drug-eluting stents that we have for the heart. Now they're doing investigations into the leg arteries for drug-eluting stents. We have stents that have covers on them to prevent the plaque from coming into the vessel again. We have devices that take plaque out of the heart, or the leg arteries, what they call atherectomy devices. We have a laser we could put into the leg arteries to evaporate some plaque. We have devices like the Foxhole that shaves the plaque off and takes it out. And we have like drills that we could put inside the arteries to drill out some of the plaque if it's very, very calcified. So we do have a lot of these toys that we can use. And why do we prefer this over surgery as first line? Well, this came from a surgeon from the surgical literature that says that when you're doing endovascular therapy, meaning sticks in the groin or in the arteries like an angioplasty technique versus an open surgical technique, You have no general anesthesia or there's no incisions. You go home probably the same day or the next morning, and you're not staying in the hospital for 3 days or 4 days or whatever after surgery. Your risks of morbidity and dying are lower. We can actually get into the treatment of the disease sooner rather than waiting for it to get a lot worse. And if you do need another treatment or another balloon angioplasty, it's only a stick in the groin. It's not another surgery. So that's why we like to try these as first-line therapies if the patient is a candidate for endovascular therapy. Now, there's some patients that have such severe disease where everything is closed up, and I won't be able to open them up, in which case they have to send them to the surgeon for a bypass of some sort, like an aneurysm repair or even a bypass into the legs. So that is all. It's like exactly like the heart. Some things we can fix with balloons and stents, and some patients have to have a bypass surgery. So it's the same thing for PAD and for the legs. And these are different examples of different stents that we have, and some of the older generations don't exist anymore. These are the kind of newer generations, and you can see how flexible the stents are, and we could put these into the leg arteries and the kidney arteries and into the carotids and every place else. Let's skip on this for a little bit because we're getting late. And this is a 60-year-old lady I did in New York about a year and a half ago. So 60 years old, history of hypertension, obesity, smoking, diabetes, high cholesterol. So other than that, she's perfectly fine. She had 5 days of off and on chest pain. So she comes to the hospital, and we did an angiogram on her. And I don't know, maybe you could turn the lights down just a little bit for this one. But there's, and I don't know if you guys could see it, but there's like a severe plaque right over here. And everybody sees it? Actually, stop right at the right time. So right over here, you can see how chunky it looks up here, how chunky it looks up there, and those are like a string going across here. So I told her that, Mrs., let's say Jones, you have a 95% plaque in the artery. I'm going to have to put a stent inside, and you'll be okay. And she said, how could that have happened? I said, well, let's summarize here. You got hypertension, you're overweight, you smoke, you have diabetes, and high cholesterol. What else would you like? So then we went ahead, and that's a wire that you see right down here, and that's a wire that we have in the heart, and we put a balloon inside, and then we put a drug-eluting stent, and this is a result where you can see there's no more plaque there. I mean, the plaque's there, but it's squashed against the wall, and the stent is kind of holding it into place, and it's basically opening up the lumen of the artery to keep it open. And this is an example of a leg artery treatment that we did. And this is a 49-year-old guy with 6-month history of progressive claudication, meaning, like we said, he kept on walking and getting pain of his leg and kept on walking and getting pain of his leg. And originally started at the calf, and he kept on walking. It went to the thigh. He kept on walking, and he started feeling the pain in the back of his butt on the left side. He went to his medical doctor for 6 months. My leg hurts. Oh, you probably got some arthritis. Take some Advil. Goes back a month later. This leg is still hurting. The Advil's out. Well, take naproxen now. Let's try that. Kept on going back and forth, thinking nobody thought that this 49-year-old smoker could have PAD. Nobody took the shoe or the socks off to check the pulses. They didn't do it for 6 months. We went back to him 6 months later, and he says, Doc, this thing is killing me. I can't walk now from here to the bathroom, and I get this pain. So he finally took his shoes off, and he says, you have no pulses in your feet. You have no pulses behind your knee. Wait a minute, you have no pulses in your femoral artery, in your groin. Go see Angelopoulos quickly. And he comes to see me, and we did the angiogram. And he had no pulses anyplace from the groin all the way down. And what you're seeing here in the angiogram, this up here is the aorta, and this is the right iliac artery that goes to the right leg. This is still in the belly. The groin is somewhere down here. And the left iliac artery, you see there's no flow down here. I had a wire across it already, and the wire alone, the blockage is right over here, the wire alone occluded the flow of the artery. So if there was a trickle down there, a little wire closed it off. So there was no flow going down to his left leg. So we went ahead, and we put a balloon in there. This is the wire. This is the balloon to open up the artery. This is the picture afterwards. And you can see it was better now. This is still a plaque over here that we still haven't opened up nicely. And then I decided to go ahead and put a stent. So this is a balloon and a stent. So the stent is mounted on the balloon. You inflate the balloon. The stent opens up. and then you deflate the balloon, take it out, and now that's the final result over here. So you can see now he's got a wide open artery going to his leg, and that's the final angiogram. You see the aorta up here, the right iliac artery, and the left iliac artery now, it's full of blood. And from the time that we finished the procedure, he got up to go to the bathroom. I went to see him like 2 hours later to see how he's doing. And he says, oh, I'm feeling so much better. I said, how do you know? I said, I just did the procedure. I just finished 2 hours ago. How do you know you're feeling better? He says, I'm telling you, doc, I could walk to the bathroom now with no pain in my leg. So he had instantaneous relief of his symptoms with this. So in summary, we're finishing up here. Diabetes management, you need a goal of an A1C less than 6%. You want to be a little bit more generous, 6 to 7%. We'll keep it at that. Your blood pressure needs to be controlled, under 120/80. Your cholesterol will need to be controlled with statins, with a goal of LDL under 70. You need to quit smoking, you need to lose weight, and you need to exercise until you drop. Enjoy your lunch now. I'm happy to say it's not in Louisiana, but this is a restaurant in Arizona. And this is called a quadruple bypass burger. And it went from a single to a double to triple to a quadruple bypass. And this place is called the Heart Attack Grill. This is an actual place. I didn't believe it. I thought it was something I saw on the internet, and I thought it was just, this is an actual place. And you can't see it from there, but I'm going to read it to you. It says, taste worth dying for. And in fact, somebody did die in there. I saw it on Fox News a couple of months ago. They had a guy with a heart attack in there. And I think it just happened like last week also. So this is what you have to look forward to when you keep on eating the food that we have down here in Southwest Louisiana. Thanks very much, and I'll take all the questions now.